Hello. It's time to go over the alterations in the genitourinary system. So let me go ahead and start the slideshow from the beginning. Here's a list of the objectives. We're going to review the anatomy and physiology of the genitourinary system, look at some common diagnostic screening tests, discuss frequently seen alterations in the genitourinary system, use the nursing process, formulate nursing care plans while looking at fluid volume deficit as well as excess, and then calculating the 24-hour fluid requirements. That was done in Safe Medicate, so that will not be covered in this particular lecture. So the concept of elimination that we're looking at is waste formation in the form of urine or stool, and then moving to waste excretion. Interrelated concepts to elimination, we're looking at nutrition, fluid and electrolytes, mobility, cognition, and oftentimes acid-base balance. So fluid and electrolyte balance is the process of regulating the extracellular fluid volume, body fluid osmolality, and plasma concentrations of electrolytes. So depending on how much fluid we have, the amount of electrolytes in our system will be either low or in excess. Here's another schematic of looking at fluid and electrolyte categories, looking at fluids, looking at extracellular fluid, the osmolality if we're in excess or deficiency, and then also looking at the electrolytes, sodium, potassium, etc. Again, looking at optimal versus excess or deficiency. We hope that everything is optimal. So looking at fluid and electrolytes, again, the same types of things: elimination, mobility, acid-base balance, nutrition, but also adding in gas exchange and perfusion. So when we're looking at risk factors of populations at greatest risk, anybody's at risk, but those at greatest risk for bowel or urinary elimination issues would be children, infants, older adults, just as in the nutrition lecture that was done previously, as well as pregnant women. And so we need to make sure that the fluid and electrolyte balance is in sync. And then as well as looking at the very young, the very old. It can also depend on cultural factors, socioeconomic status, race, and ethnicity. So moving to common diagnostic tests. Our lab tests are always important. So urinalysis, urine culture and sensitivity, looking at the BUN, the blood urea nitrogen, as well as the creatinine, testing for occult blood in the stool. You can also have x-rays, CT, MRIs, ultrasounds can also be very valuable. And as we had for the gastrointestinal, colonoscopies can also give us information, as well as for GU problems, cystoscopies, and uroscopies. When taking the patient history, you want to be looking for symptoms of fluid and electrolyte imbalance, which are often hidden, not seen, very nonspecific. So you wouldn't necessarily ask the patient, how is your fluid and electrolyte imbalance lately? Because they're not going to know what you're talking about. So going back to that vomiting and diarrhea, tell me about your urinary pattern. Tell me about your bowel movement pattern, how frequently, watery, formed. Have you had a history of any organ failure? Have you, are you experiencing any dizziness, shortness of breath, cramping, edema, changes in weight, and trying to ask those in terms of an open-ended question as opposed to a yes or no answer. We also can do daily weights, monitor their intake and output, check for safety, provide comfort measures, oral hygiene, always patient education, and then doing our fluid calculations, especially for our young patients, and limiting intake when perhaps they're prone to edema. So this slide shows you the amount of extracellular fluid in older children compared with adults and infants. So here's a schematic of the intracellular and the extracellular. Here's plasma, interstitial fluid. And you'll notice that in adolescents, the extracellular fluid is about 20% of body weight, and intracellular is 35. So it's about 55, 60% in an adolescent. However, in an infant, it's 75 to 80%. And in children, preschool children, in this example, 60 to 65%. So infants have a greater proportion of their body weight that is intra and extracellular fluid. So that means that they're more susceptible to rapid fluid changes, more than likely depletion, as opposed to excess. This is another graphic that shows you the same thing, just in table form. So in trying to put it into perspective, if you're looking at a toddler or preschooler who is approximately 26 pounds, 65% of their body is water. And so the percentage of extracellular fluid in weight is 30%, which is about 7.7 pounds. So is it a good thing to lose 7.7 pounds from a 26-pound toddler? No. That's why when you're weighing the child, that's why it's so important and such a good indicator of fluid balance to do the daily weights. Whereas for an adult, although 60% of the body is water, say they weigh 154 pounds, their percentage of extracellular fluid is 30 pounds. So 30 pounds from 156 pounds is 126. So not optimal, but much smaller percentage of actual body weight. So that's why it's very important to have accurate information regarding infants and children. So different factors that affect fluid balance for infants and children. The evaporative losses are increased because they have an increased body surface area. The metabolic rate is higher, the respiratory rate is higher, so there can be losses there. The kidneys are very immature, especially under age 2, and so it's very difficult for the children that are younger to concentrate the urine, to conserve water, to process high sodium loads, and to achieve acid-base balance. So what do you need to know? Let's talk about urine output, BUN, and creatinine. So if you look at the normal values for BUN and creatinine, they're given here. You can read those as they're taken directly out of your book. But you'll notice that for a newborn, they can have anywhere from 3 to 12 milligrams per deciliter. And the blood urea nitrogen is what gets built up when the kidneys are not excreting. So the 3 is better than the 12. You want a lower number. Lower number means you're more hydrated. And the same with the serum creatinine. The other thing you want to look at is specific gravity of the urine. If it's a low specific gravity, then you have a fluid excess. If it's a high specific gravity, then you're in a fluid deficit. That is compared to water being 1.0. And then some terms to be familiar with: oliguria, which is a decrease in urine output; anuria, which is cessation of urine flow; and polyuria, which is greater than 2.5 liters per day in adults and 2.5 to 3 milliliters per kilo per day in children. So remember, in children, we're doing the weight. We looked at weight in terms of fluid intake, and now we're looking in terms of output. So if the oliguria would be considered less than 1 ml per kilo per hour in infants, and less than 0.5 ml per kilo an hour in children. So here again is looking at the specific gravity, telling how the kidney can concentrate urine. in the normal adult, 1.003 to 1.030. And so you notice that the infant, although the lower end is the 1.003, even the neonate is 1.002, but what is considered high is much lower in an infant. You can also have increased, when you have increased glucose, protein, and dye, that can also falsely elevate the specific gravity. Another thing you need to know would be the minimum acceptable urinary output. So adults, we know that, that's 30 mLs per hour. But to put it in terms of children, again, it's mLs per kilo per hour. So for a child less than 2 years old, 2 to 3 mLs per kilo per hour is the acceptable output when you're looking at the average over the 24-hour period. So review of the kidney, you all know that. There's a picture, bladder, urethra, kidneys, ureters. And then back to the nephron for all you biology buffs. Looking at the glomerulus, which is the part that actually filters the blood, Bowman's capsule, all the tubules, going in, getting filtered, and then being excreted. So when you're looking at differences between adults and children's kidneys, the kidneys will operate at the level appropriate for the body size. Infants don't concentrate urine as efficiently as older children or adults. And because the child has a shorter urethra, that can predispose them more to urinary tract infections. And then hopefully by the age of 4 to 5 years, the child has achieved complete bladder control. We would hope earlier, but sometimes it just is not meant to be. So this reviews the function of the kidneys, what they're trying to do to filter for us. And when we are assessing for possible genitourinary dysfunction, we should also consider looking at other assessment data, altered growth, generally stunted growth, any skeletal anomalies, hypertension, lesions, and of course, immune dysfunctions. So now we're going to talk about different anomalies of the genitourinary and reproductive tracts. So the urethra can be positioned in a male in a place other than at the tip of the penis. You can have what's called hypospadias or epispadias. And we have pictures of this coming up. So on the left-hand side is epispadias. So that's a dorsal placement of the urethral opening. And then we have hypospadias, which is a ventral placement. So hypo being under, so that's underneath on the underside. And then the epispadias is on the top side. You can see that again in your neonatal assessment, newborn assessment. It is not necessarily a medical emergency at that point. We just want to make sure that urine is being excreted. So you would let the physician know as soon as possible. HYDROCELE is the excessive fluid in the scrotal sac that's surrounding the testicle. If there's HYDROCELE that persists beyond the first year, then they will do surgery. We had talked about transillumination, so that's a pen light. They should be wearing gloves. And so this is kind of like the hydrocephalus that we looked at with the transillumination. And then this would, this is fluid here on this ultrasound that's showing you there. It often gets resorbed, but you can see that there's no mass. It's clearly illuminated. Cryptorchidism, where the testes fail to lower into the scrotum. Generally, one testicle, not both, but it can be both. And so the testes are warmer when they're up in the abdomen. The sperm cells can begin to deteriorate. If both testes are involved, then there could be a potential for sterility. And oftentimes you'll see an inguinal hernia, especially when both testes have not descended. The secondary sex characteristics are not affected because the testes are continuing to secrete the testosterone directly into the bloodstream. And so here is a picture. This shows you a true there's abdominal, that's the inguinal canal, suprascrotal. The testicle should be down in this region, but this is where it can remain. And then you can also have ectopic, where they're not in the canal where they're supposed to be. And so this is a picture with where the testicle could potentially be. And cryptorchidism on my NCLEX boards was the one thing I couldn't remember when I got the question about it. So there's that. So treatment, you can do hormonal management, may help the testes descend. You can do an orchiopexy to improve the condition that lowers the testicle into the sac. There could also be an increased risk of testicular tumors with this condition. So we should provide scrotal support. Again, post-op, checking for infection, prevent contamination of the suture line. One of the things that we can do that we probably don't do enough is teach testicular self-examination starting at an earlier age, providing emotional support, and remembering, depending on how old the child is, could be a couple years old, and for the parents as well, it can be sort of an embarrassing situation. And remember developmentally where the child is when explaining things, because they'll be scared. So some more disorders. Phimosis would be the inability to retract the foreskin. So it can't be pulled down or retracted from the tip of the penis. There's a tightened foreskin, and that's why. And so you can get inflammation of the glands. The circulation can be cut off. And there's also something called paraphimosis, which is when the foreskin is retracted, but you can't move it back up the penile shaft. Both can be very painful, and oftentimes circumcision is performed, pain medication, and trying to reduce the anxiety is important. Here are some pictures of testicular torsion in infants. So the spermatic cord becomes twisted and cuts off the circulation to the testicle, which can lead to infertility. So if it is in this picture, you can definitely see the paleness there. And then this is more dark. This is darker, and so it's being pulled upwards because it's twisted on itself. In older children is generally where I've seen it, not as much in infants, but there is an intense scrotal pain, a pain like the child has never felt before. They can also, as a result of the pain, have nausea and vomiting. And what happens if the spermatic cord has twisted enough, the circulation to the testicle can cut off, and the testicle can become ischemic. So generally speaking, they do an ultrasound to see, to look at the circulation with the spermatic cord, and surgical correction is done fairly quickly. This is a medical emergency, so generally within 4 hours. And what they will do is untwist the spermatic cord and then suture it, or they call it tacking it down, so that it doesn't twist on itself again. And therefore it usually does not recur, but it could on the same side or on the opposite side. Cordy, where there's a ventral curvature of the penis, can occur in the setting of hypospadias, where the opening is on the underside, the bottom part of the penis, but it could be isolated, as in the picture that's here. It is a contraindication to circumcision, but it can be done at the time of the surgical correction. So what they will do is go in and loosen up the tendon that's in there, so that there isn't any more curvature. Moving on to female disorders. This is what is called a paraurethral cyst. So it's in the urethra, it's a cyst, it can be removed surgically. I think I've seen one of those. The vaginal or hymenal tag is this little pink part under there, and I've seen quite a few of those. They're much more common than one would think, and does not really need to have any intervention done, but you can reassure the parents that it's all right. And then this is actually an exstrophy of the bladder. The bladder is actually outside of the body. That would be the umbilical cord there, and the scrotum and the penis. And then we'll see if this link will take us where I want it to take us, which I think it's going to do. If you wanted to look further into different abnormalities with male or female genitalia, this link here takes you to Stanford. They have a very good website and photo gallery that shows you normal male and female genitalia, as well as some abnormalities, and talks about how to fix those. It also, the site also, which I think is great, has, again, this is for newborns, has galleries for different issues for the head and the eyes. There's the head circumference that we've talked about, different issues with the nose or extremities, that type of thing. So it's a really nice resource, I think. So this, for instance, is a normal hand crease right there. And then if we go to the next one, this would be a transverse palmar crease. So it can be indicative of Down syndrome as well. So that's what we were talking about when we talked about trisomy 21. So we'll close that out. We'll go back to our PowerPoint, and that is, now we're going to move on to talk about enuresis. So enuresis, difficulty in maintaining bladder control. So this can be at night, like a history of bedwetting. The child's often unable to sense a full bladder. It's really not much of a concern until they get older than 5 or 6, when they should have reached the ability to have control of their bladder. And then you can also have diurnal enuresis, meaning that there's inappropriate wetting during the day as well as at night. The parent will take the child to the physician. They'll try keeping a behavioral diary. How much is the child drinking prior to bedtime? Any behavioral, psychological counseling, sometimes setting alarms to wake the child up to void. They also have pads that have alarms in them that when they start to get wet, they will alarm to wake the child up. And then desmopressin, acetate, can work generally with the older children in conjunction with some of these treatments to help decrease the amount of urine that is produced. So you can also have obstruction in the urinary system when you're looking at, so here is our picture of the bladder and the kidneys here. And at any of these junctions, you can have obstructions or stenosis where there's a narrowing. And then you also want to observe the urinary stream of the male and newborns to discover where the opening is. There would not be a test question on this, looking at the different grades of vesicular-ureteral reflux. So this is a common cause of urinary tract infections in infants because the urine is just sort of sitting there, and so the bacteria is floating around, and it can also work its way back up the ureter, back into the pelvis of the kidney, into the kidney itself, and then you can also get this dilation of the ureters and the pelvis and the calyces of the kidney. So UA versus a urine culture, right? You understand that. We've talked about that. The urine culture will pinpoint specific antibiotics based on the organisms found in the urine. pediatric specimen collection bags. I think somebody in my pediatric clinical group was helping with that. And for the culture, the straight cath is required for infants to get an accurate diagnosis of urinary tract infection. But if you're just trying to see if the child has a if you just want to do a UA initially, then you can use the specimen collection bags, and you just have to be careful how you place them so that you don't contaminate the specimen with stool. And make sure that you cleanse the site, and you need to refrigerate it if you're not taking it to lab immediately. And here is a picture of bagged urine collection and emptying it into the container to be measured. So some of the sequelae or consequences from having scarring of the kidneys, that comes from recurrent urinary tract infections where the ureter is inflamed and can inflame the kidneys as well. More frequently seen in infants that are less than a year. There's less perfusion to the kidney. And then what happens is because the renin-angiotensin mechanism, remember back to first semester, it's triggered to release aldosterone, and so you end up with sodium retention and fluid retention, which then leads to high blood pressure. So if you're seeing high blood pressure in children, you're probably going to want to think kidney. So again, conditions that would predispose infants and children to UTIs, obstructions, stasis, any anatomic differences, if there's a susceptibility to infection, urine reflux, urine retention while toilet training. So oftentimes they don't want to use the potty, so they'll hold the urine. And then sometimes in uncircumcised infants, you can get bacteria, and that can cause a urinary tract infection, as well as sexual activity during adolescence. So sometimes a female patient will have the symptoms of a urinary tract infection and go to the physician, and when you're doing the assessment, you can ask, depending on the age of the child, for the parent to step out, but you should check and see if there's been any sexual intercourse. And so we've gone over that. And then clinical manifestations that you'll see. Infants are vague and nonspecific, but feeding difficulties, that's your #1 indicator that there is a problem of some type. Poor weight gain, irritability, and often what you'll see is when they urinate, they'll cry when they're urinating. Now there's a diaper on, so if they start to cry and you check the diaper, that's probably a pattern that you will see. You could also see a change in the urine color or an odor to the urine. And you might also, the child might have a fever, or the infant might have a fever. In children, it's more similar to adults. So you have some suprapubic or abdominal pain, the voiding, frequency, urgency, which is very difficult to measure in an infant. Enuresis, bedwetting, we'll also see a fever. And if it's pyelonephritis, if it's a kidney infection, then you tend to see a high fever with chills and back pain and the costovertebral angle tenderness, and the person looks sick. So collaborative care, this is a urine culture and sensitivity report here in the picture. You can oftentimes renal ultrasounds to see if there's an obstruction or to look at the anatomy of the kidneys and the bladder. You can do the voiding erythrocystogram where there is dye injected, and so you can see the pattern of the urine going through the kidneys, and then continue to do urine cultures to make sure that the antibiotics are being effective. And then you always do the culture first, right? And then you start the antibiotic. So generally we're talking ampicillin, some of the cephalosporins, aminoglycosides to be started after the cultures are obtained. Urosepsis would be as the body becomes more and more septic, and then you're going to want to increase their IV fluids and their PO fluids as well to keep them hydrated and flush everything out. Make sure, as always, you take the teaching with the parent and the children to take the medication for the full course of the medication, teaching wiping from front to back, don't hold the urine, continue to drink fluids, cotton underwear and bubble baths, avoiding bubble baths are good things to do, and good hygiene for sexually active adolescent girls. So now we're going to take a look at acute glomerulonephritis. And again, here's our little glomerulus, our little nephron. So what happens with glomerulonephritis is there is a streptococcal infection, and then the bacteria invade. And so you get inflammation and obstruction. And the glomeruli are actually damaged. And so there is a decreased glomerular filtration rate. The glomerulus cannot take the excess fluid to filter it. You tend to see this in children from 5 to 12 years old. So generally speaking, it's the group A beta hemolytic strep, and that can come from strep throat, sometimes from impetigo. You generally see it 10 to 14 days after the strep throat, and you'll get decreased, you'll have protein in the urine, potentially some blood in the urine, not as much urine output, tea-colored urine with protein, lots of protein in the urine. And then maybe 3 to 6 weeks after impetigo. So that takes a little bit longer than the strep throat. 95% of the children will recover. And sometimes you'll see glomerulonephritis with systemic lupus. But generally speaking, if the child's had a strep throat, then you might want to be educating the parents to watch their urine output. So the blood in the urine is sort of a smoky or tea-colored urine, mild proteinuria, and then you will see edema because there's fluid excess because the kidneys can't filter the fluid, and so and the hypertension because the glomeruli are damaged. Decreased urine output, there could be abdominal or flank pain, often a fever, and then because of the fluid retention, you might hear crackles when doing your respiratory assessment because there's actually pulmonary edema. So in the urinalysis for glomerulonephritis, you'll see RBCs, red cell cast. Generally speaking, in the complete blood count, normal WBCs, but decreased RBCs because the glomeruli are damaged and the blood is going out in the urine. So we're losing blood there. Throat or skin culture will show up strep positive, or there'll be a history of strep throat in the recent past. There is also an immune study that's done, a positive ASO titer, an anti-streptolysin titer, which indicates the presence of antibodies against streptococcus. So if you do that test, it's indicating that the patient had a strep infection, which we would expect because they have glomerulonephritis. So a positive ASO titer would be an expected finding. So nephrotic syndrome, also having to do with fluid excess. The picture here shows the swollen eyes, the swollen face. And in this case, you're getting albumin excreted in the urine, protein excreted in the urine, so you have decreased protein in the plasma itself. So that leads to edema due to the decreased oncotic pressure. So 85% of children, nephrotic condition is idiopathic. It's minimal change nephrotic syndrome. You can't really tell that there's anything going on, maybe a minimal change in the appearance of the glomeruli. Mostly occurs in children 2 to 5 years of age, and there will be a high amount of protein, greater than 3.5 grams per day, and possible trace of blood. So there is in your book similarities and differences of nephrotic syndrome versus acute glomerulonephritis, but they are very similar. And this just gives you a schematic of where the edema comes from, the hyperlipidemia, the glomerular damage. So what do we as nurses do about that? How do we assess? How do we intervene for these fluid excess? So you're measuring abdominal girth, doing the urine testing, strict I's and O's. So once the medications have started and the patient's starting to do better, they're going to diurese, meaning they're going to, where they were oliguric, they're now going to start to put out urine. And so then you need to decide, do they then need fluid restrictions? You also don't want to be giving them too much fluid until they start to diurese. No added salt or low salt diets, prednisone to decrease the inflammation, diuretics to help release the urine, antihypertensive, you know, depending on how edematous the child is, looking at, you know, loose clothing, some hats, rest and emotional support for sure, and for the parent as well. And then there could be a risk for infection because of the use of the steroids. And so you want to monitor the visitors closely, and you're not going to be giving any of the live virus immunization. So no MMR or varicella immunizations until everything has cleared up. So collaborative interventions comparing nephrotic syndrome and acute glomerulonephritis, the prednisone for the nephrotic syndrome because of the edema. And so prednisone, you started at like a high loading dose, and then you taper it off over several weeks depending on the patient's response. They have a decreased albumin, so you can give that IV, different diuretics, the low salt, no salt, and then prophylactic antibiotics. And then for the glomerulonephritis, again, blood pressure medications if necessary, and diuretics are considered blood pressure medications. First-line blood pressure, hypertension medications, the low salt diet, and don't necessarily need antibiotics unless there's a persistent strep infection, because the glomerulonephritis is a result of having had a streptococcal infection. So Wilms tumor, this is a nephroblastoma. So this is a type of cancer. It's fairly rare, but you never know when a question about Wilms tumor will show up. And so this picture here actually showing an infant. There's the regular kidney, and here is the right kidney with Wilms tumor. It's one of the most common malignancies that is seen, possibly with a genetic basis, and you don't really see symptoms in the early stages until it starts to, the tumor starts to overtake the kidney. And what will happen is the parent will be changing a diaper, helping the child get dressed, giving a bath, and feel an abdominal mass. Or if when they go for their normal checkups, the physician will find it on a routine health checkup. And the intravenous pyelogram will show a growth. The tumor compresses the kidney tissue, and it usually kind of grows over it and encapsulates it. The tumor like kind of eats it up. And so one of the things that you may see is hypertension, because the kidney isn't functioning correctly. This is an actual picture of a Wilms tumor. It has pretty much like this right here is a little part of what's left of the kidney, and that's the ureter over there. This is the tumor. And it's got a little pseudocapsule around it. You can see the kidney and the ureter there. So there's surgery, radiation, and chemotherapy. Usually the kidney is removed as well as the tumor. And one of the key things is to teach the parent not to press on the mass. So they may call again to see if they need to bring the child to the physician. And if there's a palpable mass, you ask them, tell them, please do not press on that. That is very important. And then the physician would also avoid abdominal examination once they're going to do an initial one, but then once the other tests have come back, then there shouldn't be more abdominal examinations because the cancer cells can be moved around and spread. And we certainly don't want that to happen. So acute kidney injury, we're on to our last couple topics here, acute kidney and chronic kidney. It used to be acute kidney disease, now it's acute kidney injury. And so you have different types, 3 different types. They're called pre-renal, which would be pre-kidney, intrinsic, which would be having to do with the kidney, and then post-renal, having to do with an obstruction of the urine outflow. So when you're thinking of pre-renal, it's the result of some condition that decreases perfusion of the kidney. So the kidney's not perfusing. If it's intrinsic, it's actual damage to the kidney. And then if it's post-renal, it's usually a result of an obstruction of urine flow. And so the obstruction increases the pressure, which then decreases the renal function. When you have poor renal function, your glomerular filtration rate decreases, and then you have a decreased urine output. And then azotemia is an elevated blood level of the urea, the BUN, the creatinine, uric acid. And then you'll also start to see electrolyte imbalances. The GFR will return to normal faster than the transport mechanisms in the kidney. And so you will get diuresis first, large amounts of dilute urine, and that of course puts the child at risk for dehydration. Eventually the renal function would return to normal. So this is not a chronic thing. This is a relatively short period of something that happens due to the obstruction, which gets fixed, or if there's damage that gets fixed. And this is not a chronic thing. So what you'll see is the increased BUN, creatinine, poor feeding, vomiting, can also lead to seizures. And so tests that are done to check with that, you're going to do your history, your assessment, asking about, again, here's your vomiting and diarrhea, fever, looking at signs and symptoms of dehydration, any bloody diarrhea should be noted, fluid volume status, so dehydration would be seen, whereas the children that have an intrinsic acute kidney condition from glomerulonephritis, for example, they're usually fluid overloaded. So they have edema and crackles and hypertension. So pre-renal kidney injury is associated with dehydration. Intrinsic kidney injury is generally associated with fluid overload. And always if you're hearing crackles, that is a sign of fluid excess and overload, and the physician needs to be notified. And then your serum creatinine BUN we talked about, you can get a metabolic acidosis, and also potentially hyperkalemia, because you might have dehydration, which then will give you hyperkalemia. So when would you dialyze the patient? When would that need to happen in acute kidney failure? Perhaps with severe fluid overload to take the load off the kidneys. If there is in fact pulmonary edema or congestive heart failure, because again, you need to get the fluid off, get the kidneys working again as best you can. In cases of severe hypertension, hyperkalemia, things that are not responding to medications, or if there's a BUN greater than 120 milligrams per deciliter. And then talking about chronic renal failure. So this would be an irreversible loss of kidney function over months to years. So these are the patients that have end-stage renal disease. I know some of you were doing your first semester clinicals on the renal floor, so I'm sure this is what you were seeing. Patients are on the kidney transplant list. They're on dialysis 3 days a week for at least 3 hours on those days. Some patients might have home dialysis. That would be nice to be able to stay home. But it is a multidisciplinary care team that will be taking care of the patient and the family. So you need to keep that in mind as well. And that would be the end of the PowerPoint. So hopefully that gave you the information that you need, the specifics. And as always, let me know if you have any questions, and I will be seeing you on another Zoom meeting somewhere this week. Thank you so much.